Welcome back to Cardiovascular Lecture number 17. This is part 2. In this part, we're going to briefly consider the causes and consequences of heart failure, in particular congestive heart failure. And this is going to allow us to review and apply some very important clinical concepts. You're going to cover both myocardial infarction and heart failure in much greater detail next year in Block 7 Cardiology. Like any pump, the heart has two ways to fail. First, inadequate emptying of the venous reservoirs. This is sometimes called backward failure. And second, reduced ejection of blood under pressure. This is sometimes called forward failure. A heart that fills poorly cannot eject a normal stroke volume. And a heart that empties poorly cannot fill normally. So the left heart must not only pump blood into the systemic circulation, develop a perfusion pressure, it must also remove blood returning from the lungs to decongest the lungs. Let's begin by defining congestive heart failure. This is when the heart is unable to pump enough blood to support the metabolic demands of the body, or when adequate cardiac output can only be maintained with an elevated left ventricular filling pressure, in other words, elevated preload. And what are the cardinal signs and symptoms of CHF? Well, first, edema, both in the dependent appendages of the body, the lower legs and lower arms, and in the lungs, and engorgement of the jugular veins, ascites, exudation of fluid into the peritoneal cavity, and enlarged and tender liver. These are all consequences of an elevated venous pressure. And this edema can cause special problems in the lung. Pulmonary edema with pleural effusion can make for poor gas exchange, further compromising the oxygenation of blood to the failing heart. Let's recap. Congestive heart failure is characterized by manifestations of inadequate tissue perfusion, fatigue, exercise intolerance, activation of the baroreflex with sympathetically driven tachycardia, and vasoconstriction of the cutaneous circulation, a low stroke volume producing a weak, thready pulse. Signs and symptoms of venous volume overload, dyspnea and ralls due to pulmonary edema and jugular vein distension. Orthopnea is dyspnea that worsens when supine, when laying flat. In fact, the severity of CHF is sometimes judged by whether the patient says they need 1 pillow, 2 pillow, or 3 pillows to prop up at night and avoid dyspnea. Nocturia. Why would patients with heart failure need to urinate, especially at night? Think about the effects of gravity on venous return. When the patient lies flat, peripheral venous pooling is mitigated, improving venous return, better preload, better cardiac output, better perfusion of the kidneys, more urine is produced at night. Heart failure comes in two forms. One form is characterized by concentric ventricular hypertrophy. The ventricle becomes thick and non-compliant, difficult to fill, and therefore the main issue in these patients is diastolic dysfunction. Although the heart cannot fill fully in this form of failure, it can still eject reasonably well with a near normal ejection fraction. The second form is characterized by ventricular wall thinning and chamber enlargement. And the main issue here is a loss of contractility. The pumping performance of the ventricle is impaired. And so these patients have systolic dysfunction, impaired ventricular contractility, and this is reflected in a poor ejection fraction. A couple of sessions ago, I mentioned that remodeling of the ventricular wall over time plays an important role in the progression of congestive heart failure. Although the process of ventricular remodeling is quite complex and multifactorial, we can model it simplistically in the following way. If the ventricle is injured as a consequence of ischemia, arrhythmia, afterload stress with hypertension or valve stenosis, or preload stress with valve insufficiency, or alcoholism, the resulting impairment in contractility will set in motion an adaptive remodeling of the ventricular wall, typically hypertrophy. And as Laplace tells us, this wall thickening will help mitigate wall tension and afterload stress. But as the ventricle thickens, it becomes less compliant and more difficult to fill, setting the stage for diastolic dysfunction. This form of remodeling is called concentric left ventricular hypertrophy. As heart failure progresses over time, cardiac output declines, and continuous activation of the renal baroreceptor and the arterial baroreceptor will drive a persistent bombardment of the ventricle with norepinephrine and angiotensin II. And these neurohumoral factors, norepinephrine and angiotensin II, over the course of months and years, will promote a more destructive form of myocardial remodeling that leads to thinning of the ventricular wall and expansion of the ventricular cavity. This is called dilated cardiomyopathy, and as the law of Laplace predicts, this will increase wall stress. More wall tension will have to be produced in order to develop an ejection pressure, and this will worsen systolic dysfunction. This form of remodeling is called eccentric left ventricular hypertrophy. Keep in mind that concentric and eccentric hypertrophy can occur together, and they depend on many factors. For those of you that might be interested, here are a few more details, but please do not worry about these details now. I will not ask you about these details on an exam. You're going to cover this in cardiology next year. Concentric hypertrophy, as we've seen, is primarily driven by chronic pressure overload, afterload stress, as would be seen in hypertension or aortic stenosis. This chronic elevated systolic stress promotes the addition of new myofibrils arranged in parallel, and this adds to the thickness of the ventricular wall and produces a concentric form of hypertrophy. As the law of Laplace tells us, concentric hypertrophy is an adaptive response to reduce systolic wall stress in chronic pressure overload. Eccentric hypertrophy, in contrast, is promoted by conditions that cause volume overload, as would occur in congestive heart failure or mitral valve regurgitation. This diastolic stress promotes the addition of new sarcomeres arranged end to end, and this adds to the length of each myocyte and expands the ventricular wall with an enlargement of cavity volume. And the law of Laplace tells us that this chamber enlargement, this increase in chamber radius, will increase systolic wall stress, promoting this process. So eccentric hypertrophy reduces diastolic wall stress in volume overload by expanding the chamber. One important aspect of these two types of hypertrophy is that they can occur simultaneously and they can influence one another. Wall thickening in concentric hypertrophy, as shown by this blue line, promotes eccentric hypertrophy, and therefore later stages of heart failure are associated with progressively severe eccentric hypertrophy and wall thinning. And this is what is referred to as the dilated cardiomyopathy stage of CHF. Another important point is that both forms of hypertrophy, especially the eccentric hypertrophy, are driven by neurohumoral factors released in response to poor perfusion pressure, that is, norepinephrine and angiotensin II. And this is one reason why the frontline therapy for CHF includes beta-1 blockers and ACE inhibitors. They very effectively help slow down the progressive destructive modeling of the ventricle by interfering with this neurohumorally driven destructive process. The term cardiomegaly refers to an enlarged heart, and this term can reflect either dilation of one or more of the heart chambers or hypertrophy of the ventricular walls. This chest film on the left is taken from a normal healthy individual, and the silhouette of the heart is outlined in green. The chest film on the right is from a patient with severe long-standing CHF. This patient has dilated cardiomyopathy, an enlarged heart, with systolic dysfunction. Notice the radiographic evidence for pulmonary hypertension, so-called curly bee lines that look like a spider web. This is pulmonary interstitial edema and the distended pulmonary vasculature. As you will learn in your pulmonary radiology thread from Dr. Chang, when you look at a chest x-ray, evaluate for cardiomegaly. Approximately 2/3 of the heart should lie in the left chest and 1/3 in the right chest. And the full width of the heart should be less than half the width of the chest wall on an inspiratory chest film. This defines the so-called cardiothoracic ratio, and a ratio above 0.5 indicates cardiomegaly, as in this patient who has severe cardiomegaly. Note the implanted pacemaker with its sensing and stimulating wires embedded in the walls of the heart. Clearly, the cardiothoracic ratio in this patient is well above 0.5. Remember that the patient in congestive heart failure is living on preload. What do we mean by that? We can illustrate that with a ventricular function curve. Normal is in gray and a patient with CHF is in blue. In this patient, there is a failure to eject blood forward, such that end systolic volume is retained, to which the venous return is added, stretching the myocytes, enabling the heart to develop greater pressure. the so-called Frank-Starling length tension effect. The downside of the heart operating at higher volumes is, as Laplace tells us, higher wall tension. And the danger of operating at higher filling pressures is that that pressure is transmitted back to the pulmonary circuit, setting the stage for pulmonary edema. And if that pressure exceeds the pulmonary edema safety factor, which is about 17 millimeters mercury, the force of filtration, hydrostatic pressure, will win out along the capillary against the force of absorption, oncotic pressure, and excess fluid will accumulate initially in the interstitium and subsequently into the alveolus. And this fluid will severely impair gas exchange, and the failing heart will receive less oxygen and fail further. This is congestive heart failure, and it sets up a deleterious positive feedback loop, a downward spiral. As the oxygenation of blood decreases, the heart fails further. As the heart fails further, there is greater pulmonary pressure, more pulmonary edema. Pulmonary edema can occur in left heart failure and in mitral valve stenosis. As we will see, the kidneys play a central role in congestive heart failure. Forward failure of the left ventricle results in systemic hypotension. This triggers the baroreflex, which activates sympathetic drive, causing vasoconstriction in an attempt to restore blood pressure. Poor renal perfusion activates the renal baroreceptor, which stimulates the release of renin, activating the RAA system. The release of renin from the kidney is further stimulated by sympathetic drive. Angiotensin II causes further vasoconstriction and stimulates the release of aldosterone from the adrenal gland. The aldosterone then instructs the kidney to retain sodium and water. Urine output is reduced, and fluid retention fills the venous reservoir and increases central venous pressure. Initially, this is a helpful adaptive response because it allows the ventricle to operate at higher filling volumes and take advantage of the Frank-Starling length tension relationship. However, stimulated by this signaling mechanism, the kidneys can load the venous reservoir with too much fluid, volume overload, and this volume overload can set the stage for pulmonary edema. How can you help your CHF patients in pulmonary edema? It would be helpful to unload the venous reservoir, drain fluid from the veins. You can do that by administering to your patient a diuretic. And as we will see, the loop diuretic furosemide, Lasix, is a frontline therapy for CHF. Furosemide inhibits the reabsorption of sodium and fluid by the kidney, and urine output is increased, unloading the venous reservoir. Another frontline therapy for volume overload in congestive heart failure is ACE inhibitors or angiotensin II receptor blockers or ARBs. They are beneficial both acutely and chronically. Let's consider why. ACE inhibitors and ARBs will block the production of angiotensin II or its effect on the kidney. The kidneys will no longer avidly retain sodium and fluid, and more urine will be excreted. This will unload the venous reservoir and relieve the volume overload. ACE inhibitors and ARBs are chronically beneficial because they help suppress the angiotensin II-driven destructive eccentric remodeling of the ventricular wall. A few words about heart sounds. Remember that two extra heart sounds, in addition to the normal S1 and S2, can often be heard in various forms of heart failure. Remember that an S3 heart sound can occur in the early filling phase of diastole as blood rushes into the ventricle. In a patient with long-standing CHF, in the dilated cardiomyopathy phase, the ventricle can be very dilated, and as the mitral valve opens, the blood can rush into an overfilled ventricle and slam into a bunch of soggy blood. This can produce an S3 heart sound, and it is typically a very soft sound that immediately follows S2. I'm so tired. I'm so tired. And this is why an S3 can suggest either CHF or mitral regurgitation. An S4 sound occurs during atrial contraction in patients with a hypertrophied stiff ventricle, diastolic dysfunction. As the atria contract and kick additional blood into this thick, stiff, non-compliant ventricle, the atrial kick will slam into these stiff walls, causing reverberations which give rise to the S4, like a stiff wall, a stiff wall, a stiff wall. Remember that a stiff ventricular wall can also result from ventricular ischemia, for example, after a myocardial infarction. Let's review those neurohumoral responses that are triggered in response to heart failure. When the heart cannot develop an adequate stroke volume to satisfy the baroreceptors, the sympathetic nervous system will be activated. This is initially adaptive. By increasing heart rate and inotropy, the stroke volume can be improved, and at the same time, systemic vascular resistance is increased, and together this will help relieve the hypotension. But in the long term, the norepinephrine will promote ventricular remodeling, increase myocardial excitability and arrhythmias, and the increase in systemic vascular resistance will increase afterload. Remember, pressure work by the ventricle, afterload work, is energetically expensive. Activation of the carotid baroreceptor and the renal baroreceptor by hypotension in heart failure will also be initially adaptive. Angiotensin II will increase systemic vascular resistance and blood pressure, and aldosterone will instruct the kidneys to retain fluid, fill up the venous reservoir to improve central venous pressure and preload. In the long term, however, angiotensin II is maladaptive. It promotes destructive eccentric ventricular remodeling, and it increases afterload stresses on the failing ventricle. The third neurohumoral response to heart failure is natriuretic peptide secretion. Remember, as the kidneys hold on to fluid and expand the venous reservoir to improve cardiac preload, this venous expansion, the atrial distension, will stimulate the atriomyocytes to release natriuretic peptide. These natriuretic peptides are adaptive. They promote natriuresis and diuresis to counteract the RAA system. They promote vasodilation and a decrease in SVR to relieve afterload stress. And these natriuretic peptides continue to have an advantageous effect even chronically. They help maintain optimal ventricular loading conditions and oppose an overly aggressive RAA system. Remember that the serum level of B-type natriuretic peptide is now used clinically as an index of CHF severity. A major cause of heart failure is ischemic heart disease. The supply of nutrition to the myocardium, blood flow, is inadequate to meet the metabolic demands of the myocardium. If we can restore a better balance between blood flow supply and metabolic demand, the function of the myocardium will be improved with an increase in cardiac contractility. We can achieve a better balance by increasing blood flow, or increasing blood oxygen content, or by decreasing the workload of the heart. Improved oxygenation of the blood can be achieved by preventing pulmonary edema. There are several ways we can reduce the workload of the heart. Because pressure work is energetically expensive, it is imperative to reduce the afterload, the arterial pressure. We can also reduce the volume component of MVO2 by reducing preload. Another approach to reducing the workload of the myocardium is to reduce contractility. Yes, it sounds counterintuitive, but the overall objective is to reduce the workload of the heart to achieve a better balance between supply and demand. The heart will function better. Finally, we can listen to Pierre-Simon Laplace, who would tell us that as we reduce ventricular radius, we can reduce wall tension, wall stress, and MVO2. How are angina and MI managed? And there are really two phases of management, acute and chronic. In acute MI, the goal is to relieve the pain of angina with morphine, to improve the oxygenation of blood, to vasodilate and relieve afterload stress, and to prevent further thrombus formation. Chronically, patients with a history of myocardial infarction are prescribed ACE inhibitors and beta blockers for the reasons that we just mentioned. The most effective way to restore a supply-demand imbalance is to reduce afterload. Pressure work is energetically expensive, and afterload can be reduced in many ways. Work your way through this flowchart and see if it all makes sense. Vasodilators are an important component of heart failure therapy. These include ACE inhibitors like lisinopril and angiotensin receptor blockers like valsartan and losartan. These drugs, by opposing angiotensin II, will act as vasodilators. The reduction in systemic vascular resistance will decrease arterial pressure and afterload, and this will improve ejection fraction and stroke volume. They will also cause a mild coronary vasodilation, which will improve myocardial perfusion. These drugs will also blunt the effects of angiotensin II on the veins. Venodilation will expand the venous compartment and decrease the preload. This will reduce pulmonary edema and improve pulmonary gas exchange. This will reduce end diastolic volume and, through the law of Laplace, reduce ventricular wall stress. The result is a decrease in myocardial MVO2. I know that this is a lot to learn and it might seem overwhelming now, but keep this in mind. This is the first of several passes through this content. You will be presented this core information recurrently from several different perspectives, and each time you will capture a little bit more. You will get there. To help you review and focus on the important concepts, I'm going to post a practice exam. The objective of this cardiovascular practice exam is not to reproduce the end-of-block exam. Instead, the mix of questions are designed to review and apply important concepts. If you work through this practice exam, you will be in good shape for the end-of-block exam. Here's an example of a question I might have on the end-of-block exam. We see here 3 different PV loops. The question might ask which PV loop best models one of these clinical scenarios. See if you can answer these, and here are some hints, and here are the answers upside down. This concludes Cardiovascular Lecture 17. I'll have one more very short video replacing Dr. Bolger's session on circulatory shock. Thanks for your attention.